Assalamu alaikum and welcome to this lecture on vulval intrathelial neoplasia. What is vulval intraepithelial neoplasia? Or let's just call it VIN. It is a vulval skin disease that might become cancerous if left untreated. However, many, not all of them, there's again similar to CIN, VIN can also regress and not develop into cancer. What is the prevalence of VIN? It is a rare disease, which but recently it has been increasing, especially in younger people or younger women. This increase is probably due to several factors. Firstly, there's increased awareness amongst physicians that changes in the vulva need investigating, need treatment, need to be paid attention to. There's also increased awareness amongst women of the same, so that they are quicker to present with any changes in the vulva. Then there's increased smoking amongst women, and this is a known risk factor similar to cervical cancer. And also there's increased prevalence of human papillomavirus. And as CIN, AIN, and also anal intraepithelial neoplasia, and also VAIN, which is vaginal intraepithelial neoplasia, similar to all of these diseases, VIN is also due to a prevalence of human papillomavirus or associated with the prevalence of human papillomavirus. Invasive vulval cancer has also increased recently. It's also extremely rare, but it has increased by 20%. So let us quickly look. I've already kind of hinted towards the etiology, but let us just look at the etiology briefly. There are two types. The usual type, the more common type, is actually due to human papillomavirus. HPV 16, but also 18, 33, and 35 are also implicated in this. This has quite a good prognosis, and it is much more common than the unusual type. The unusual type is associated with chronic infections or inflammation of the vulval skin. And this can be, for example, lichen sclerosis. This can be lichen planus. It's very rare. It's only 5% of all VIN, and there you can see how infrequent it is actually. But 85% of these will progress and become squamous cell carcinoma, and it is usually found in older women. The usual type has a better chance, a better prognosis. It's found in younger women, and it's more likely to possibly regress again. Risk factors for VIN include smoking, immunosuppression, HPV infection, and local chronic inflammation, and we have kind of discussed all of these points so far. So what are the characteristics of VIN? How does it present? How can you diagnose it? So let us have a look. The usual type affects younger women. It is associated with smoking. It's often multifocal, so you often find not only one place affected, but several places. Therefore, it you have to, if a patient presents with one lesion, you have to evaluate this lesion, but you have to also evaluate the rest of the skin of the vulva. And it is less commonly associated with squamous cell carcinoma. The differentiated type actually is more often found in older women. I made a mistake, I put younger in as well, but it's more often found in older women, and it's usually unifocal and it's quite rare. What are the presentation and signs of VIN. So present VIN can be asymptomatic. So patients can have changes in their skins. They might be visible, but they might not be noticed by the patient themselves. They might not be noticed by the physician. By the physician, so they might be completely asymptomatic and not noticed. It can have pruritus is a common symptom associated with it, and this can be mild pruritus, but in cases it can also be quite severe pruritus. You can have burning and soreness, and this can also vary from mild to severe. Then there's a change in appearance. So most VIN lesions, kind of show a change in the skin. However, the change is not uniform. So you find many different changes that might represent VIN. And this is what might be confusing about it, and why you have to have a very low threshold to investigate any changes on the vulva. So such changes can be, the lesion might be red, it might be white, it might be brown, it might be pink, it might be a lump, it might be an ulcer. So you find all different kinds of presentation here. Some women have also experienced pain in the lesion of VIN. So the signs, we already discussed them, are very variable. You might have raised white erythematous. Pigmentation is quite common. And also it might be multifocal or unifocal. If you find one lesion, you have to evaluate the vulva very carefully to look for more lesions. So these are different ways of presentation that you can just have a look at, and you can see how they are very, very, very variable. So how do you diagnose VIN? And I can hear you now say, you need a biopsy. A VIN needs to be diagnosed by biopsy. The tricky thing is that you have to often take multiple biopsies, because if you have multiple areas that do look abnormal, you have to also take multiple biopsies. Otherwise, you might take one biopsy from an area which might appear normal, while there's another area with some invasive disease even. So therefore, you might have to take multiple biopsies. The point with taking multiple biopsies is that you have to number those biopsies. And so that the pathologist knows which biopsy represent which lesion, you have to also include a drawing into your notes, as well as for the pathologist to kind of label the biopsies and with a drawing you can say, this is here you took biopsy number 1, here number 2, here number 3, here number 4, so that everybody knows from which lesion the biopsy result comes from. So this is a pathological picture of VIN, and you can see that this is actually looks quite similar to CIN. You see kind of in A, you see mild VIN, and this goes higher grade. In C, you see actually high grade VIN, and you can see that this looks quite similar with more the nucleus to cell size ratio increases with the grading, with increasing grade, and also you see more packed cells throughout all of the epithelium with increasing grades. So what is the treatment of VIN? This is very tricky, actually, the treatment of VIN, and is often a long-term commitment to follow-up and treatment with the patient. So local excision is, of course, good if it can be done. It's the treatment of choice in local and well-circumscribed lesions. However, in multifocal lesions, this can be difficult because you might have to do a lot of excisions, and this might be difficult also for the patient. Another problem is here, the lesion has to be removed completely to be removed. And the problem is that VIN can always come back. So although local excision is still the best treatment, it's not a foolproof treatment, and it has its own problems attached. Another treatment, and this is a treatment which is about 25 or so years old, it came onto the market around 25 years ago, is a cream called Yemknkum cream. This cream was initially introduced for treatment of genital warts. And it is a treatment that increases the immune response of local cells, and in that way they can get rid of the papillomavirus that caused the genital warts. With time, people noticed that it also works for VIN. It will also get rid of human papillomavirus 16, 18, 33, 35, and other types. And therefore, it can also be a very effective treatment for VIN. And especially in multifocal VIN, this can be useful. It needs to be given over a long term to be successful. So the minimum is 12 weeks, but often you need it for 20 weeks or so. So you look at kind of 6-month treatment. It should not be kind of applied every day, but only about 3 times a week. Unfortunately, it has got side effects such as a reddening of the skin. Sometimes you get some tissue erosion and sometimes some soreness and discomfort. Therefore, it is very important to explain to patients to kind of apply it only very thinly, scarcely to the areas, and to only use it 3 times a week or 2 to 3 times a week, and not more than that. If you have a lot of recurrence or problem, then or you have very wide and very severe, so you took biopsies and you found very severe VIN, so that you are kind of thinking this might develop into vulval carcinoma, then a vulvectomy might be the only choice for this patient. And of course, this is a very radical, very invasive treatment that should be avoided if at all possible. You can have problems with function and with the cosmetic results afterwards. And we're going to talk about vulvectomy a little bit more when we come to talk about vulval cancer. At this point, and as well as in the earlier point, it is very important to treat these patients with a multidisciplinary team, and to make such decisions only with a multidisciplinary team. So a pathologist, gynecological pathologist should be involved, a dermatologist should be involved, a gynecologist, of course, has to be involved, so that all of these can make the decision together and see how the response is to the treatment. There's other treatments, but none of them are really foolproof. And we don't have enough evidence for any one of them. There's local destruction by laser, sometimes cryotherapy or ultrasonic waves. The problem with this is always that it might cause local destruction and reactions such as skin appendages, but there also might be recurrences in the same area. There's another cream called 5-fluorouracil cream that is a little bit controversial because it kind of produces very, very severe local side effects, with a severe inflammation, pain, and discomfort in the local area where it is applied, so it is not tolerated well by many women, and also recurrences after use of this cream are common. There's another way of managing VIN, and this is by observation. This is especially kind of works by milder partial thickness VIN, and because there you have a higher chance for this to regress. Observation is only feasible if you have a clinic that is set up for this, and you can take photo evidence to kind of see the progression. Because if a patient comes today to you and then she comes back in 3 months' time, you will not remember how it looks in any one patient. Therefore, you have to take photo evidence of the area, and then when she comes back in 3 or 6 months, depending on what you agreed with her, then you can kind of take another picture and compare the two. You can keep these pictures in a digital format, which makes it easy for you to kind of keep an eye on the changes, and hopefully find that hopefully they get better. However, one more thing I have to add to this to this form of treatment is that patients also recognize any changes very well, and you have to explain to the patient that she also has to monitor any changes that kind of occur with time or that she notices. And if she notices any more changes to this to the skin or so on, she should come and see you immediately and make you aware of such changes. So let us look at the general management. As I said, this should be with a multidisciplinary team. The cervical cytology has to be kept up to date. As the VIN is due to HPV infection, there might also be cervical changes, and therefore also there might also be CIN. Therefore, you have to keep cervical cytology up to date. Any patient where for the first time you diagnose CIN, she has to also have a colposcopy to make sure the cervix is healthy, or to diagnose any changes if they are there in the cervix. You have to also be alert to AIN and tell the patient if she has any problems in the perianal area. She should always make you aware so that you can evaluate that area as well. If you do find any changes in the perianal area, then she needs an anoscopy and she needs to be seen by a specialist for that. I already mentioned that you should have a regular follow-up and documentation with pictures, and that these pictures should be kept in a digital format so that they can be easily compared. So what complications can you imagine resulting from VIN and its treatment? One problem is, of course, the development of squamous cell carcinoma, and 9 to 18% of women do develop squamous cell carcinoma. A second problem is that a patient undergoes treatment, and some of this treatment is very invasive. If you think about the Yimkicum cream with its side effects for half a year, or if you think about wide local excision, maybe at several places, and in very tragic cases, women undergo vulvectomy, and still they might have recurrence after treatment. And this is a real problem, of course. Another problem are the psychosexual consequences that might result from a surgical treatment. Therefore, as with cervical cancer, here also prevention is better than cure. HPV vaccination and stopping smoking are the best ways to prevent VIN, and this should be a general kind of advice for all women to do or to follow. In summary, VIN is a rare illness, but it is increasing. It is always important to assess any chronic vulval lesions. Close follow-up and observation is needed, and cervical smears need to always be kept up to date. There's a very variable clinical appearance, that therefore these lesions need biopsy for diagnosis, and treatment and management should be by a multidisciplinary team. Thank you very much. And next we will have the lecture on vulval cancer to kind of look at this topic.